Thank you, Maya, for making me part of this instructional course. So, as Maya said, I'll be talking about the trabeculectomy as a first-line surgery in favor of trabeculectomy. So there has been debate about the first line of surgery, whether it can be tube or a trab surgery as a primary surgery in the conditions where glaucoma cannot be controlled by medical management. Although the medical claim data shows that there is increasing trend towards the tube surgery, but however, a recent survey done by American Glaucoma Survey Society, the trab is still most preferred surgery in America for the primary cases. Now, why to compare trabeculectomy and tubes for a primary surgery? So I have two questions. Why not to consider trab as a first-line surgery? Is there any doubt about the success of immediate or long-term success of trabeculectomy? To clear this, we have a 20 years follow-up study of trabeculectomy. So John Landers and Keith Martin have done 20 years follow-up of trabeculectomy. So those surgeries were done in 1988 or 1990 were followed for 20 years. This was a retrospective cohort study. And the main surgical outcome was IOP less than 21 millimeter mercury after 20 years without medication. This was defined as complete success, and with medication was defined as qualified success. So what they found that even after 20 years, 57% of patients had a complete success after trabeculectomy, and these included secondary glaucoma as well. And 88% of patients were qualified success. That means the IOP was less than 21 millimeter of mercury with medications. The risk of failure was pseudoexfoliation aphakia and uveitic glaucoma. So around 60% of success rate after 20 years of trabeculectomy. So that vouch for the trabeculectomy surgery. So this trabeculectomy is a very successful surgery in the long term for IOP control. And the other point, which is in favor of trabeculectomy, is that trabeculectomy can be customized based on the case-to-case scenario and also based on the expertise of the surgeon. So one can do a triangular flap, can do a rectangular flap, releasable suture, use of mitomycin can also be customized based on the condition. And surgeon has liberty to customize it and get a favorable result in trabeculectomy. However, in the tube, the surgical steps are very confined and fixed, and one cannot modify it much. There is a learning curve in a tube surgery. So most of us are familiar doing trab from our residency day or post-residency period. Even in United States, Dr. Francis, who was the investigator of tube versus trab study, have failed that there is a mental block or biasness towards trab because most of the surgeons are not very familiar with doing a tube surgery. So surgeon's comfort and experience is definitely much more in doing a trab, so that can bring more success to the surgery. And what are the options available if the tube fails in the first place? So trab is very easy. One can do a trab surgery. If it fails, one can do a needling. If it completely fails, then one can do a second trab and then tube, one tube and then second tube. So there are many options available. But what if someone puts a tube in the first place, then there's no question of trab, or trab is very difficult to perform. The next option is putting an inferior tube, and the other option will be, after failing this, the other option will be doing a cytophotocoagulation or disruptive procedure. So options are limited if you go for a tube procedure in the first place. However, trab gives a wide variety of range. And there is also concern about the tubes. Dr. Francis, who was an investigator of T versus trab study, felt that many patients are conscious about putting a plastic-like material inside the eye, which they are going to have for their life. Also, if you put a tube in an early case of glaucoma, there is high chances of erosion or extrusion of tube in a longer period. So this is a landmark study of primary tube versus trab study. This study actually compared the placement of primary tube versus trab in virgin eyes. So total 242 eyes were enrolled, in which 125 patients were enrolled in tube groups. So main outcome measures, surgical failure were defined by IOP more than 21 millimeter of mercury or less than 5 millimeter of mercury. So this is the Kaplan-Meier plot, which showed that at the first year of surgery, trab has a better success rate as compared to tube. Though after 3 years onward, success was similar in both, but the need of medication or complete success was much better in a trab group as compared to the tube group. So trab should be a preferred surgery because it can bring more success to our surgical groups. And there is a role of baseline IOP as well. And this study by primary tube versus trab study showed that patients with lower baseline IOP has lesser success rate with tube plantation as compared to the trab. So all the normotensive glaucoma patients, those category of patients will benefit more with the trab surgery as compared to the tube surgery. So take-home points are, So trabeculectomy has a lower risk of failure as compared to tube shunt surgery, particularly at lower IOP. Baseline IOP is very important in case of primary tube surgery. So, and also the need of post-operative medications and complete success is much better in TRAB as compared to tube surgery. Although tube surgery can be considered in few cases where the patient cannot come for follow-up very regularly, or the surgeon is very much bothered about the immediate post-op complications and doesn't want to go through the rough patch of immediate post-op period, then only those cases tube can be considered. Otherwise, most of the cases, TRAB can be still considered as a primary surgery for a primary glaucoma.